Good evening, everyone, and welcome to this seminar. My name is Johan, as my esteemed colleague just said, and without further ado, let us begin. So, just a brief introduction regarding the anatomy and physiology of the kidney. So, the primary function of the kidney is to clear our blood from all manner of substances. And, of course, the kidney is supplied via the blood from the renal artery, and from there, the blood passes to the renal pyramids. These are aligned along the outer edges of the kidney, and there the blood meets the urine, and the substances to be cleared are passed through down to the urine. This whole outer region of the kidney, the cortex and the renal pyramids, are what we traditionally call the parenchyma, and these will be important later on. From the renal pyramids, the blood passes down to the pelvis, where it empties via the ureter down to the bladder. So why do patients come for a renography scan? There are several reasons. It might be a renal failure, a disease, an obstruction, hypertension, scarring, and it might also be pre-chemotherapy investigations. There are a number of reasons why we do the renography, which is why also it's done in so many different ways, and also why there are so many quantitative measurements to choose from. So I'm not going to talk about how we perform the acquisition, the image acquisition. So for the purpose of this talk, we're going to assume that we receive the renogram from the camera, and let's now talk about what to do with it. So normally we need to delineate the kidneys, as you can see in this image here. This is both easy and a little bit tricky at the same time. It's easy because the kidneys are usually easily defined. They're clearly visible against the background, unless we have a disease or obstruction, of course, which hinders the flow. However, we do want to include all parts of the kidneys, both the outer parenchyma regions, but generally we also want to include the renal pelvis. And as I described earlier, activity comes in through the bloodstream, goes to the parenchyma where it's transferred to the blood, and then down to the pelvis. This means that in the early stages of the renogram, the parenchyma will light up and be clearly visible, whereas the pelvic region is still not as visible. And this reverses in the later stages of the renogram, where the parenchyma might fade, but the pelvis lights up, like I have in my image here. So when one does the region drawing, one has to ensure that all parts of the kidney is present. A question might arise why we want to include the pelvis, and some hospitals don't include it, but the recommendations for EANM and SNMI says to do so. And the reason is that we might have a lot of renal tissue behind or in front of the renal pelvis, which might be excluded if we don't include the pelvis. Then we have the parenchyma regions, which are inside the kidney roys. They are C-shaped, and one has to be careful not to include the pelvis. If one goes too far down, it might creep up into the pelvic. And then we have the backgrounds. The backgrounds can be half circles, like I have in my image here. They might be C-shaped, or they might be a complete circle as well. The EANM guidelines says C-shaped, but any one of these is fine. However, the quarter circles, which was very popular a decade ago, at least in Scandinavia, where I originate from, have now gone out of fashion, and for good reason as well, especially on the right side, where we will not include the liver if we only have the lower quarter circle part of the background. So we have drawn on our kidney, and now we of course want to have the perfect renogram. So in a perfect world, we injected a bolus which enters the kidney artery all in one go. So all activity reaches the kidney simultaneously, and blood activity goes down to almost zero instantly. Because we have an extraction of 100% from the blood, the activity then rests in the kidney for 3 to 5 minutes, passing through the renal pyramids, and then extraction down to the bladder occurs. And if this was the case, this is how a renogram would look. The red curve, that would be our blood time activity curve, enters the kidney and then drops to zero as it is extracted. The kidney function has a plateau, which are these 3 to 5 minutes, since we have a complete uptake. And as those minutes have passed, the extraction phase begins and the curve decreases as we are extracting down to the bladder. So that's what we would like to have. However, reality. So in reality, we might have a nice bolus, but it will never be perfect. Activity concentration in blood goes down over time instead of instantly reducing to zero. For MAG3, we have an extraction rate of perhaps 60% per pass. Activity passes through the kidney with varying speed, especially when we're talking about deceased patients with possible obstructions, which also causes the extraction to might occur after it has passed through the kidneys. But with deceased patients, we might have accumulation in the pelvic region instead. So with this in mind, something like this is how our time activity curve would look like for the renogram. And our problems doesn't really stop here, unfortunately. The thing is that this renogram, this time activity curve, is actually built from several different components. First of all, we have the surrounding tissue in front and behind of the kidney, which will also take up activity. And we're going to talk about the background subtraction in a few moments, how we deal with this. However, we also have blood activity in the kidney. And this is actually the one that's going to cause us the largest problem when it comes to background subtraction. And then we have the kidney itself, the true kidney function that we would like to use for our quantification. So in order to correct for these disturbances, the C-shaped background regions, they will correct for the surrounding tissue in front and behind of the kidney. However, they will only partially correct for blood activity. And if we have the same vasculature in the surrounding tissue as we would have in the kidneys, this issue would not arise, and the C-shaped backgrounds would correct for blood activity as well. But since the kidneys have a rather unique vasculature, they will not be identical to the surrounding tissue, and thus we will still have an undercorrection of the activity if we only use the C-shaped background. But more on this later actually. We're going to solve this issue further down the line. But as of now, we're stuck with only the C-shaped background regions. So what do we want? The most commonly used quantitative measurement is the relative function. So this is how large proportion of activity goes through either of the kidneys, expressed as a percentage with the sum for the left and right adding up to 100%. A healthy subject would have a 50-50 division, so 50% of the activity goes through the left kidney and 50% goes through the right kidney. And as a rule of, and now I'm really ruling of thumbing here, but if it's more than 5-10% off, then that's usually an indication of a disease or obstruction. And the four methods we have available to determine the relative function are the integral, the Pathlike plot, or the Pathlike plot as it's called, the slope method, and deconvolution. So let's go through these one by one. The relative function integral method is simply the time activity curve integrated during the uptake phase. So you can see it highlighted in pink in the plot there. And we want to estimate the activity for the right divided by the sum of the activity for the right and left, or vice versa. It doesn't really matter which one we use. And this will give us our percentages. The guidelines estimate this to be about between 90 and 150 seconds, but this can vary between different hospitals. Some use 60 to 120, some use 60 to 150, so it varies, but it is within this region. It is, however, important not to go too early or too late, because we truly only want to be within the uptake phase of the curve. And we also do an assumption that the kidney depth is equal for the two kidneys. If this is not the case, we do need to correct for this, as this error can be quite large. And possible ways to do this is to measure the kidney depth by taking an angled image, or do both anterior and posterior and do a geometric mean image. And please do keep in mind that this assumption on kidney depth applies for all of the quantitative measurements for the relative functions, also the other three methods, so it's not unique only to the integral method. But it is quite easy. It's not a very complicated method, as long as one can stick to the uptake phase only and not allow the integral to go before or after it. So let's talk a little bit about the Patlak method now, as it is a little more complicated, but also a little more interesting. So I'm going to take you on a little detour, it's not a long one, to tell you how we arrive with the Pathlike plot. So the kidney system can be expressed as a three-compartment system, where activity travels between these compartments. So we have the blood, and this is both blood inside the kidneys, but mostly when we look at this system, we're considering activity outside the kidney region. So this would be outside the kidney region of interest we draw on the renogram. We have the tissue and we have the urine. So the activity can go between these compartments with varying speeds. And these speeds are denoted by these rate constants K1, 2, and 3. The blood and the tissue can exchange activity. Once again, this is done in the top of the renal pyramids we saw earlier. And the activity can wander back and forth. No, I'm very sorry. In the renal pyramids, it goes between tissue and urine. And there it can only go one way. But between blood and tissue, it can wander both ways. And this is very important because I'm going to stress this a little bit later, but the Patlak method will not work if we have a backflow from urine to tissue. That's one of the assumptions of the Patlak method. And before some of you are screaming reflux at me, the urine we consider here are actually part of the kidney region. So it is not urine down in the bladder, because from there we can truly have a reflux. But activity can generally not wander from the urine back to the tissue in the renal pyramids. So when we draw on the image, the kidney region data is both tissue and urine combined. So this means that we have to draw another region for the blood, and this is usually located in either the heart or the descending aorta, depending on what is available. The Patlike method, what we want in the end, is this speed k, big K. This describes the speed with which activity wanders throughout the entire system, i.e. how fast activity travels from the blood to the urine. And if you're interested, here is how it's related to these minor constants, but that is purely for those who are interested. So we want to determine the K, the big K. And our assumptions then, the first one we already mentioned, that we need to have an irreversible uptake in the final compartment. And we also need the flow rates, the individual flow rates, to be constant. And this complicates things because in the early part of the renogram, the first minute more or less, these flow rates will not be constant because we still have a bolus. The Patlike method assumes a steady state activity in the blood. We don't allow it to have the bolus shape, meaning that we can't use the first minute and a half of the renogram acquisition. But we can't use the later stages either, because then the urine compartment isn't irreversible anymore. It will start emptying down to the bladder. And that is why the Pathlike plot can only use a specific part of the plot, which is more or less the same as the integral method. It's the uptake phase. So this is the equation for the Pathlike plot. I'm not going to derive it, so you simply have to take my word for it. CT is the activity concentration in the kidney roid, the tissue, over time, but remember it's both tissue and urine inside the region. And CP, this is the activity concentration in blood plasma. However, this looks suspiciously like a linear equation. We can just replace these nasty terms with just y and x. So this means that if we plug then in all the data points for the different times, since we have a dynamic acquisition, we can plot this in the so-called Pathlike plot as a linear equation, or as a linear equation. And the slope of the curves will be the K value. And we can only use the part of the curve that is linear, because as the urine compartment starts emptying down to the bladder, then the model dissolves and these plots will not be linear anymore. So the one I'm showing you right now is the right and left kidney for a single patient. So when using the Pathlike method, we have to be very careful to only stick to the initial linear part of the curve, because otherwise we would break these assumptions. So it is not a very complicated method either. But we have one thing here we haven't really talked about yet, and that is the plus V sign. And that would be where these lines, if we extrapolated them to the y-axis, would cut the y-axis, where they would hit the y-axis. Because that actually has a use as well. In many situations, when you use Pathlike plot, it is disregarded, but in the renogram situation, it's very useful. And V is the distribution volume of tracer in the tissue. So let's talk a little bit more about that one. Since the V value describes how large distribution we have of blood in the kidney region, the kidney roy, we can use this to describe the blood. And you remember when we talked about the backgrounds, I said that we have a problem subtracting the blood activity because of the unique vascularity of the kidney, since we can't estimate that with the C-shaped background regions. But we can, however, calculate it using this V, this distribution volume of tracer. So from here, we can further refine the background correction. And now we can subtract the final part of the background, and which will leave us with only the kidney data and the kidney curve for those regions. And this means that even if you use the integral method for determining the relative function, it might still be affected if you do a Patlak calculation, since the Patlak calculation will be used for background subtraction. So I've seen some situations where hospital staff has been a bit confused over this, but this is the explanation why. So we jump back to our relative function. We have the slope method, which is very similar to the integral method. It is simply the slope of the renogram curves during the uptake phase, and then we compare these. So in a way, this is a sort of average between the integral method, because we use the same time intervals as the integral method. Guidelines said 90 to 150 seconds, you remember. Whereas here we use the slope instead, which is what we did for the Pathlike plot. But it is rather straightforward, and in my experience, most people use the integral or the Patlak method. The final method, and beyond a doubt the most complicated one, is the deconvolution method. What we really want is to estimate the ideal kidney time activity curve. You remember this one? This is what we looked at in the beginning. So if we would have this one, then it would be a lot easier to estimate the different values we want. So the ideal time activity curve can be solved with the equation you see on the screen here, which is a deceptively complicated one. The capital F's are Fourier transforms, and the F-1 is the inverse Fourier transform. So this is a non-trivial problem. It is certainly solvable, but I'm going to talk, when we compare the methods, I'm going to discuss a little bit why it isn't used as often as the others. Even just the subtraction of the blood activity curve is a non-trivial problem, since the nature of these Fourier transforms forces us to assume that the blood activity curve comes in the shape of one or more boluses, which it isn't, as we saw previously. However, if we could solve this well, it is very easy to use. The initial height of the plateau is the kidney uptake, since it takes everything from the blood according to the model. The duration, i.e. the length of the x-axis, is the transit time, and the downslope is elimination. So it's easy to read once you have it, but rather difficult to obtain. So let's compare these methods. I'm going to merge the integral and the slope, since they are, for many intents and purposes, similar. So all of these functions can give us the relative function. That was the point of all of this. However, only the deconvolution also supply us with the transit times. Both the Patlak and the deconvolution can facilitate vascular background subtraction. The integral will not do that, but it can use information from the Patlak to do this. And now we start listing why deconvolution isn't as widely used. First of all, due to the nature of the Fourier transforms you need to do to solve it, it is very sensitive to noise, since noise will propagate throughout that algorithm. It is also rather sensitive to timing errors in when you start the image acquisition, when you administer the activity, and so on, since it assumes those perfect boluses from the blood. Whereas the Patlak is very robust and the integral is even robuster. Finally, both the integral and the Patlak method can be used in combination with furosemide or other substances to encourage the patient to void, whereas deconvolution cannot be used. Since once again, the algorithm has a very strict requirements on how we suspect all these time activity curves will look like. And if we then encourage the patient to void, we break this. So those, I would say, are the things to keep in mind when selecting which method you want to use. Let's go and talk about some other common quantitative measurements we like to obtain from the kidneys and the renogram. First, we have the transit times, and this will be acquired via deconvolution. So even if you don't use it for the relative function, if you do want the transit times, those will be calculated via deconvolution. And as we said previously, the distance from the x-axis is the transit time. So the minimum transit time will be the length of the plateau, since potentially a molecule could enter the kidney and then be the first to leave once the extraction phase begins. If we extrapolate the curve all the way down to the x-axis, we get the maximum transit time. And perhaps the most commonly used is the mean transit time. So this simply says the average time a molecule will take passing through the kidneys. Another common value is the residual cortical activity. And it is simply the ratio between the renogram at 20 minutes compared to the peak. And then we multiply it with 100 just to view it as a percentage. This is normally calculated both for kidneys and the parenchyma, but we are interested in the cortex and the parenchyma in this case. You remember that the parenchyma is made out of the outer parts of the kidney, which is the cortex and the renal medulla in this image here, the renal pyramids. So a normal rule of thumb, a normal person should be below 20%. And this way we can ensure that the parenchyma is emptying the way it should at the end of the study. We can look at the outflow efficiency. This is expressed as a percentage between the total outflow of the kidney and the total inflow to the kidney at up to a specific time. And the standard, the most commonly used, is to look at this at 20 minutes. For healthy subjects, the outflow efficiency after 20 minutes should be above 82%, meaning that 82% of activity flowing into the kidney should have flown out. And it can also be presented as a plot over time. The outflow efficiency is most commonly used when the renographic response from furosemide is ambivalent or not as clearly visible, perhaps due to poor renal function or a gross pelvic dilation. Many times this is then solved by simply letting the patient rest for a while and taking a late image. But if this too is ambivalent or due to time constraints, the outflow efficiency can then be an alternative or an addition to acquiring a late image. The outflow efficiency is also very closely correlated to the normalized residual activity, or Nora, which is also a ratio of the activity for minute 1 to 2 and the last minute of acquisition. It is, just like the outflow efficiency, a robust indicator of renal obstruction, and there's a high correlation between the two. A few hospitals use both, or they use just one of them, though the Nora is, of course, much easier to calculate, but if you have software, it doesn't really matter, but they usually show similar results. A final note on the Nora is that it can also be used with the first to second minute in relation to a post-mixed image, 1 minute of a post-mixed image as well, so it doesn't necessarily have to be the last minute of the original acquisition. There are other methods available for that as well. And my final topic is the glomerular filtration rate, or GFR. So we're going to spend a few minutes on that as well. The GFR describes the flow rate of filtered fluids through the kidneys. And once again, now we're talking about these renal pyramids where the filtration from blood to urine occurs. And if we look at more in detail how this works, this is how it looks like. So the arterial blood branches into the glomerular capillaries, which is enclosed in what's called a Bowman's capsule filled with urine. And from there, the impurities or tracers or substances can wander between the two via osmosis into the urine. Then the blood continues, and it can actually repeat the process further down the line in the peritubular capillaries as well, before the renal vein expunges the blood from the kidney back into the rest of the body. So we want to measure the speed with which the blood is cleaned in this process. And it's usually expressed in this way as a milliliter per minute, so a volume per time, and then normalized to body surface area. And here you see the normal ranges for adults under 40. After 40, these values decreases with about 1 millimeter per minute in body surface area per year. And the most common reason to do GFR is because the patient is scheduled, or at least the idea is that the patient will undergo some treatment, most often toxic substances like cytostatica for cancer treatment. And we want to be sure that the kidneys can keep up with the toxins so they don't accumulate in the body, becoming dangerous for the life of the patient. So it can be cleaned. And extremely simplified, the GFR can be expressed as urine concentration of whatever substance times its flow and divided by the plasma concentration. So there are many ways we can do this, and I'm going to go through a few of them just so we can see each and every one's advantages and disadvantages. So the first method is with creatinine. So this is not a renogram. The patient is injected with creatinine and the levels are monitored by blood sampling. It is very easy to perform and measure. However, the reason why it's not the most common method is that, first of all, creatinine occurs naturally in the body, which means that we will overestimate the GFR. And the excretion rate also heavily depends on, for instance, muscle mass, making it very variable between persons and hard to say if it's high or low. Therefore, a much more common method is with inulin. It works the same way. We inject it intravenously and we measure it by blood sampling. However, unlike creatinine, it doesn't occur in the body and the excretion rate is not dependent on muscle mass or other factors. So today, it is the most commonly used method to determine GFR. But let's then talk about how we can do it with a renogram. There are very different methodologies in work here. They depend on the tracer used because the modeling of how the filtration occurs varies depending on which tracer is used. Most of them have the possibility to also include a blood sample or two in order to increase precision, but it's not necessary. All of them have shown to be rather reliable, but especially DTPA and EDTA have been shown to be very accurate with the gold standard Inulin. So since there are different methods, I don't think we need to go through all of them. So I'm just going to quickly talk about the DTPA Gates method to determine the GFR. I'm going to throw in some equations, but my idea is mostly to talk about what we need during image acquisition and processing to acquire the GFR. So first, we want to calculate the depth-corrected kidney counts, meaning that we need to subtract both background, but we also need to correct for how much activity was absorbed when the photons traveled from the kidney to the detector. Meaning that we need the blood activity curve, we need the kidney ROI, the backgrounds for subtraction. We also need the depth of the kidneys because we need to know how much activity was attenuated. Meaning that we need either to measure this, or more commonly, we can use a model based on the gender of the patient, its height, and its weight. We also need a camera calibration. However, this does not need to be done for every patient, but we do need to be able to travel between the world of counts and becquerels. And once we have this, we can estimate the total percentage of renal uptake over 2-3 minutes, which is what's usually used for the GFR in this case. We calculate the depth-corrected kidney counts for both left and right, and we add them together, and we normalize it to how much was injected. So basically, before and after injection, we note how much is left in the syringe, and we normalize to this. Very similar to how you do for SUV, where you also normalize to injected activity. And we multiply with a factor of 100 to get a percentage. And from there, with some constants, we can estimate the GFR. So the discussion usually comes down to Inulin or Renogram. And Inulin is rather easy to perform. If GFR is the only thing that's requested from the patient, a complete renogram becomes, at least in relation, quite an expensive process. However, on the other side, if we have a renogram for any other reason, or if we require some other quantitative parameters, GFR can be estimated using one of the above mentioned methods. And since the correlation between the renogram GFR is very good in comparison to the Inulin, at least in my opinion, it might be a bit of a stretch to also do an Inulin investigation if a renogram is present. So, with that, I would like to thank you so much for your attention. I hope you found it interesting and worthwhile. And with that, I hand it over to my colleague Helena, who will take care of the Q&A session. Thank you very much.
Thank you, Johan, for that really interesting and very thorough, clear presentation of renogram techniques. I felt like I was back at school. We will now take questions from the chat, so please type in your question. And I know that renograms are one of the most variable nuclear medicine exams, both in the same country and internationally, and people often have strong opinions that their methods are best. So I hope we can get a good discussion going here. I have a question first off. You were mentioning Inulin there for GFR measurement. I don't think that's really used at all in hospitals in the UK anymore. We would do a blood sample with DTPA, a single sample ideally, for measuring that, and then measure that in a gamma counter rather than use imaging techniques.
Yes, I certainly agree with you. When I reviewed the literature, the UK was specifically mentioned as an exception to this Inulin gold standard.
Good to know that we like to be different.
Maybe you're right.
Okay. So we have a question from Aram Parthipan. He says, how is the outflow efficiency calculated?
Yes. I could throw up some equations if you would
Do
like.
it. I think that's what everybody wants.
Everybody wants equations. So please hold one moment as I bring them up. I hadn't prepared a slide with that, so please bear with me. Here we go. So normally what you do is you take the integral of the plasma curve, and the uptake interval depends, now I'm more reading aloud, I hope that is fine with you, whether which of the methods you use, the Patlak or integral method instead. And you subtract the kidney function from that, and then you divide it with, once again, the integral of the plasma function. So you form the output curve, more or less, the output function, by subtracting the kidney from the integral of the plasma curve. It's not a very thorough explanation, but perhaps it points you in the right direction.
Great, thank you. That's Johan is showing there the hybrid viewer Renogram manual, which is a mine of wonderful information. So please refer to that if you want to in future for more equations. So we have another question. GFR is the most important clinical variable to measure next to percentage function. The Gates method, especially using height, weight for depth correction, is based on old planar imaging. Has any effort been made to use SPECT or other methods to get a proper depth correction?
Not to my knowledge. I've been looking through the literature now in preparation for this talk, and I could see some early beginnings of it, but unfortunately my answer would be, at the moment, not really, though it would be very interesting. I do believe we're held back a bit about the reluctance of doing SPECTs for kidneys in general.
What do you mean? Sorry, why are we reluctant to do SPECTs of kidneys?
Now I'm talking a bit from the perspective of Scandinavia, and I would love to hear from the rest of the world. But in general, kidneys are not slotted into SPECT times on cameras in Scandinavia. They are stuck to planar images.
Yes, they're probably right, to be honest there. Yes, I think that if you're a DMSA, I guess that's where I have most come across the request for a SPECT would be for a DMSA to make it more clear rather than just the planars. But you're absolutely right that normally we would not schedule a SPECT slot for those. Yeah, that's true. I think as well, just to add to the answer there for the SPECT question for the Gates method, is that, again, giving the UK perspective here, we would prefer to do the radionuclide counting sample method rather than an imaging GFR. We think that the imaging GFR is actually not so accurate. So perhaps, Bob, yeah, that would be my answer to that one.
In regards to the accuracy of the imaging GFR, there's also a bit of a trend in the literature where it has been very critical of the imaging GFR, but in recent years there's a slight shift, and I don't know if this is due to better cameras or better methodology, or if it's just wishful thinking.
is that from, I know the German nuclear medicine community seem particularly keen on imaging GFR. Is that mainly from German groups?
Not really.
Okay.
I would say it's a general view, but it's still just a very slight trend, so we'll see which way the pendulum swings within the coming decade, I'd say.
Good stuff. Okay, we have a question. What about Nora in very dilated pelvis?
The problem with that is that if it's very, very dilated, you would have a very late, let's go see if I can go back to the Nora just so we can see what we're talking about. There we go. If it's a very dilated pelvis, the outflow will be either delayed, or if you have an obstruction, not at all, causing it to be very wildly inaccurate, I'd say, since we do have ranges in which the Nora should fall in order to estimate this. But on the other hand, if it's very late, the excretion, then you would also get a very odd number for the Nora indicating this. But of course, you might then misalign it for an obstruction. But
I mean, it would be possible.
Yeah.
Sorry to interrupt you. It'd be possible to draw the kidney region, not including the pelvis. Maybe that would be the.
Might be.
That would be the Nora just for the sort of cortex part of it then. But maybe that would be a useful thing to know.
It's not a bad idea, especially if you see it on the images that it's so big.
Yeah. Okay, another question from Aaron. Do you recommend any quantitative measures for assessing transplant kidneys?
No. Oh, I'm very sorry, but I'm gonna do a little bit of a pass on transplant, as I have not looked on that for this particular talk.
That's absolutely fine. I'm very happy to take this question. I think so. I know that in fact Dr. Parthpan is working for the Royal Free Hospital, where the Hilson Transplant Index was partly developed. So that is something in the Hermes Renogram package. But I have recently done an audit of that at the hospital where I work part-time, which is St. Bart's Hospital, and we found that because the technique that we're currently using is quite different from the one that Hilson developed that measurement with, the results are really quite variable and very dependent on where you put your regions. So one of the main changes is that the bolus technique that was used during Hilson's time was called the Oldendorf bolus technique, which basically you put a ligature on the patient's arm, inject underneath that, and then let it go. So you have a big proper bolus. And also he was injecting probably twice as much activity, so it was much less noisy. I think you'll find if you try to do the processing on these cases, often it's very tricky to see the iliac artery, which is what you're trying to draw as part of that measurement. So we found for our clinical practice at Bart's Hospital that it's not a reliable measurement. And other than that, I haven't really seen much more stuff out there on how to quantify transplant perfusion. I guess all of it suffers from kind of the same stuff, is that you've got a noisy image and it can be very tricky to pick out the iliac artery. But yeah, I'd be interested to see where that goes, if there is anything more out there. So it's a question that people ask often, I think, is how to make an assessment of that. And for now, I think we just recommend visual assessment based on the perfusion portion of the uptake. Okay, the next question. Thanks for a great presentation. I have a question regarding C-shaped background regions. Would you say that they are inappropriate also for when using the Patlike plot, since, as you mentioned, this method can take into account the blood background?
No, I don't think so. The reason is that when we do the Patlike background subtraction, we do it as an add-on, meaning that the C-shaped backgrounds will, as I said previously, will under subtract the images, but we won't over subtract it with a large margin if we include the vascular background subtraction from the Patlak. On the other hand, if we were to remove the C-shaped background, then we would have the problem with the tissue background instead. So while it's true that we might be doubling up a little bit, it's still the best of many worlds. I hope that answers the question.
Okay, great, thank you. We have another question. So we in Florence are using from 40 years a method very similar to Patlak Plot to obtain about 50,000 absolute monolateral functions and an equal number of transit times. The question is how UHR low energy collimator, the ultra high res low energy collimator energies versus all purpose high res affect those measurements. I think that's the question.
I'm sorry, is the question whether it affects your results or the Patlak? I guess you mean the Patlak.
I think, yeah, I think she's trying to say if they changed collimator to this ultra high res versus a standard high res, would they be expecting a quantitative change in the transit times?
In the transit times, I would say there's a risk for it, since you remember we said that the deconvolution technique used to estimate the transit times is very, very noise sensitive. And if you go from a high resolution to an ultra high resolution, you will have a change in noise. So I would guess that yes, for the transit times, it might make a difference. For the Patlike plot itself, I don't think it will make that much of a difference. But I'm guessing a little bit now.
Okay, lovely, thank you. You stated that inulin clearance is superior to creatinine clearance for estimating GFR. However, the Gates GFR method employed creatinine clearance as the gold standard for computing GFR. Is that a problem? A little bit of a loaded question there, I feel.
I feel so too. I'm trying to think how I'm not going to put my foot in this hornet's nest.
I mean,
yeah, please.
Yes, I would say that yes, it is a problem, and that's why the UK community does not really trust the Gates method of clearance.
I would agree with you.
I feel like we're about to cause some sort of international diplomatic incident here, but great. Okay, I think we are reaching the end of the questions now. Let's wrap it up there. So thank you very much again, Johan, for a really informative presentation and for taking those questions.
Thank you so much, everyone. And with that, I wish you a very pleasant evening, and thank you once again for joining us.
Goodbye.